Good morning everybody. Welcome to our seminar. My name's Tim Stockwell. I'm Director of the Centre for Addictions Research at BC. And it's my pleasure to introduce our eminent speaker, Dr. Cheryl Cherpitel. Cheryl is a senior scientist at the National Alcohol Research Center in Emeryville, California. So the US National Alcohol Research Center. She's also, we're very proud to say, a scientist at CABC. That's us, the Centre for Addictions Research. And in Emeryville, she's also director of the WHO Collaborating Centre on Alcohol Epidemiology and Injury. I think I've got that title correct. But what you really need to know about Cheryl is that she's actually, in the field of alcohol and injury research, she's royalty. She's widely known as the queen of alcohol and injury research. Cheryl pioneered studies in emergency rooms down in California. I think in the early 80s is when it started. Very simple idea, but an awful lot of work and skill developing the protocols to interview people in acute trauma situations to find out what they were doing in the little window of time before they had their injury, with a focus initially on alcohol use, but increasingly the studies have looked at other substance use. We have a study, Cheryl and I are co-PIs on, looking at the combination of alcohol and energy drink use as risk factors for injury at the moment. So since the 80s, Cheryl has started this wonderful project, the ERCAAP, Emergency Room Comparative Alcohol Analysis Project. Something, might not have got it quite right, but it's collected at least 40 countries over the years, probably 150 emergency room sites in different parts of the world. And Cheryl is like, I remember my school days in physics learning about the structure of atoms. You know, there's an electron that orbits the, what's the big thing in the middle, the neutron or whatever. Is it? It's the main part of the atom anyway. The point about the electron is if you don't think you know where it is at any moment, it isn't. There's some scientific principle of uncertainty principle. You never quite know where it is. And I think Cheryl's like that. She orbits the world. You think she's in Seoul and she turns up in your office, or you think she's in Emeryville and she's actually in Moscow or Liverpool in England. It's quite amazing that you're here actually, and I'm sure you're going to vanish shortly. So the point of all of this accumulation of studies and collaborators all over the world, she has this wonderful data set, huge, rich data set, capable of addressing very fundamental questions about the relationship between alcohol and injury. And today, Cheryl is going to enlighten us on some of the recent findings that get more and more interesting and fundamental, I think, as time goes past. So, alcohol and injuries in international perspective. Thank you very much.
Well, thank you, Tim. That was just so glowing. I hardly know where to go from there. It's going to be downhill, I'm afraid, after that. I would like to thank, of course, CABC for inviting me, and Island Health, especially Cindy Triton and Annie Morrow. And I would also like to acknowledge that we are on the unceded Coast Salish territories. So, as Tim said, I'm going to be presenting the project that we had that started in the early 80s, 1984 to be exact, and is continuing to go on alcohol and injuries based on emergency room studies. Okay, so I thought I'd give you a little background on alcohol and injuries, and then from there carry on into what we have done with the emergency room and what we know from some of these studies. Alcohol is a major risk factor for injury, morbidity, and mortality, and this is globally as well as in most countries individually. And the latest WHO statistics estimates that alcohol attributable injuries constitute about 1/4 of all alcohol attributable deaths and about 1/3 of all alcohol attributable disability adjusted life years. And that is related to the mortality that is accumulation of days lost from productivity due to injury, morbidity. So this just gives you an idea here. You can see the red line. That is where alcohol stacks up as a risk factor globally. And you can see it's at the very top. It is only surpassed by underweight and unsafe sex around the world. And then alcohol is next. So as you can see, it just is a huge risk factor in health. So this is just a pie chart that shows the quarter of the injuries that are attributable to alcohol. Let's see if I can do this. Okay, so this part of the pie chart, I can't hardly see where this little arrow is here. Well, I sort of. There, oh, there we go. Okay, I got it. Yeah, that's the problem. This part, if you add it up, those are different kinds of injuries. Oh, I can use a mouse for, okay. Yeah, well, let me just see how it goes here, because that,
Just a point.
so that, well, that would probably be a little easier, because then I can sort of control it. Yeah, okay, thank you, Annie. Yeah, so you can see that here the injuries related to alcohol are a quarter of the pie, and all the rest of the health conditions related to alcohol attributable deaths make up the rest of the pie chart. And the same for the morbidity attributed to alcohol consumption that we have here. Fires, drownings, mechanical force poisonings, violence, and so on make up a third of the pie chart for all of the mortality related to alcohol. So there's been a growing recognition of fatal and non-fatal injuries as a public health problem globally, but we didn't have a very large understanding of the role of alcohol in non-injuries, in non-fatal injury events. So in order to better understand this relationship, we began a series of studies in 1984. And this started at San Francisco General Hospital, and we decided that we would sort of jump into a situation that would probably be one of the most difficult, because San Francisco General Hospital was a very large emergency department, seeing about 220 patients a day. Obviously, we couldn't interview all the patients coming through, so we had to take a probability sample of every nth patient, so they would be representative of all the patients coming through. We were interested not only in injured patients, but also of alcohol involvement in non-injured patients. And the reason for this is that we needed a comparison group. If we found a certain prevalence of alcohol among the injured, we might not know if that was high or not. So we had to have a comparison group, and we used the non-injured patients as a comparison because we thought they would be very similar in demographic characteristics and other things that we might want to sort of rule out. So as Tim said, this had not really been done. There had been one small study in the 60s at Boston City Hospital, but this was the first time that a large study had been sort of undertaken. And we just didn't know how well it was going to go because, as you can imagine, emergency departments, and some of you may actually be working in those departments here, that it's very difficult to find patients, to gain informed consent, to be able to interview them. We also breathalyze them. It was sort of a challenging situation. And so as our first attempt, we hired 18 people that we trained. We interviewed every fifth patient coming through, 24 hours a day, 7 days a week for 2 months. We never left the admissions station. At that time, admissions were not computerized, so people just came in and then they were recorded in this log book with the name and all. We were there, for the 2 months. And it was interesting because it was during the Christmas holidays, there was New Year's, a Grateful Dead concert, Valentine's Day, and so there were a number of occasions that, even though the sample might not be representative of the whole year, it certainly showed you how the fluctuation of alcohol and injury could change according to sort of what was going on out there. So it was interesting. Following that, and there was an early conference in, actually here in Canada, in Ontario, outside of Ontario, well, in Ontario, outside of Toronto, at Scarborough Bluffs. And that was the first international conference on alcohol and injury. And following that, then there was a lot of interest with some other countries. So we were able to conduct studies, similar studies in Spain, in Mexico, and in Italy. And that grouping became known as the Emergency Room Collaborative Alcohol Analysis Project, or ERCAAP. We have since added on studies to that, but that was sort of the first core of studies. So this gives you an idea of what all was included in that. We had our studies in the U.S. We had 8 emergency rooms in Mexico City. The unique part of that was that every kind of emergency department in the city was represented. And so it was a unique sample from that standpoint. You can see down here that we also included in these early studies Canada. We have Alberta and we have Quebec. And Tim conducted a study in Fremantle. And we have Spain, Italy, Argentina, and more recently Poland. So that has been sort of the core of the ERCAAP studies. Just sort of as an aside, you probably realize that patients who show up in the emergency department are not really representative of all injury patients. People can have injuries that don't come to the emergency department. Of course, if the injuries are very severe, they don't get there because they die first. But you can imagine if we tried to, say, go out to the general population and interview people about alcohol and injuries, that it would take huge numbers of patients to find very many people who report, say, even in the last year, having an injury. And then they're remembering whether or not they had been drinking at the time and so on. So we felt that even though the emergency department might not be representative of all injuries out there, that it was really a good place to find injured patients, obviously, and that it was a good place to begin this work. So building on that, the World Health Organization then undertook studies in 12 countries in 2001 and 2002. And this shows you we have Argentina was both in ERCAAP and WHO. We have Belarus, Brazil, another study in Canada that I think was in Orangeville, China, Czech Republic, India, another one in Mexico City, a couple in Africa, New Zealand, and Sweden. And in addition, the Pan American Health Organization has conducted a number of studies in Central America. And we have other studies that are, the data have been collected. We haven't had time to add them yet to our data set, but they've been collected, a number that have been planned. The NIAAA, US NIAAA, has conducted studies in Asia. They just finished one in Tanzania. And we have the new study funded by the CIHR, and so you will know, most of you or some of you, that that study has 3 sites, one being here at Royal Jubilee, and 2 sites in Vancouver. And we've extended the research agenda a little bit from that, in that rather than just looking at alcohol and injury, we are also looking at other drug use, which we have with some of these data sets, but we're concentrating a little more in this study on the other drug use, and especially zeroing in on energy drinks. Because there's a lot of, well, not a lot, but there's some data now that energy drinks may cause injury, and we don't know very much about the interaction of alcohol and energy drinks with injury. So that's one of the unique pieces of this study, and I would like to give special thanks to, at this time, to the management and the staff in the emergency department here. We're really appreciative that you have let us come in, are allowing us to do the study. Jessica Johnson has been instrumental in helping us facilitate the study, and Dr. Chris Hall and Dr. Chris Morrow have both been very supportive as well. So we're really totally appreciative that you are allowing us to continue our data collection efforts here in Victoria. So this is probably sort of smallish, but this shows the new data set that we've added. We have another site from the US, we have Ireland, Switzerland, Sweden, 2 sites in Korea, but then we have more at a later study. We have Vancouver General, which we collected several years ago. It was sort of a pilot study that we did, and then we have a number of sites in China, as I said, more sites in Korea, and then we have the Central America that the Pan American Health Organization was instrumental in helping us collect. We have Taiwan and Thailand. These data are going to be added very soon, and Costa Rica, Tanzania just finished. Our study here will soon be added. And Japan, New Zealand, and Vietnam are, and also France, I have to say, are also getting into the picture in terms of organizing studies. So, Tim was a little overly generous with what we have in the data set right now, but probably by the time we get done with the studies we haven't added and the new studies, we will be at these phenomenal numbers. But at present, with what we have, and with some of the analysis that I will be showing you, we have 96 ED sites in 30 countries and over 22,000 injured patients arriving to the ED within 6 hours of the injury event. This just shows geographically, it says 40,000 patients because we have non-injured patients as well. So this sort of shows you just, globally. This doesn't include, we don't have little points for a lot of the new studies, but this gives you an idea that we really have quite a global representation of emergency departments. And as I mentioned, we have collected representative samples, so each patient sample is representative of the emergency room where the data were collected, but that does not mean they're representative of anything outside of that emergency room. So we have to sort of keep that in mind. And all of these studies use the very same questionnaire and protocol pretty much that I developed in 1984. So the unique point of that is that we can combine all these data, merge them together, and then do analysis with what we think are really huge numbers of injured patients. It turns out we never have enough by the time you start looking by gender and age and injury type and cause and different things. But we're adding on, so we will be able to do even more. So this gives you an idea of the basic core questions that we ask. We ask the reason for the emergency department visit, type and cause of injury, whether it was intentional or not, drinking in the event, the amount they consumed, the time between the last drink and the event. We ask whether or not they were feeling drunk at the time of the event, and then we ask, did they think that alcohol caused the injury? Would the injury have happened if you had not been drinking? We also look at the context of drinking and the injury, where they were, who they were with. And then beyond the event itself, we ask the quantity and frequency of usual drinking. We also ask about heavy episodic or binge drinking. We also have obtained the both ICD and DSM criteria for alcohol dependence and harmful abuse. We ask about the number of prior ED visits, and we have found, and not surprisingly, that people that fall into our ED samples are heavier users of the emergency department than people who don't, obviously because they have a greater likelihood of falling into our sample if they come all the time. And in fact, I have to say, at the very first study I did at San Francisco General, when I went in to set up the study and talked with a lot of the physicians there and the staff, they said, oh, this is a fabulous study, everybody's an alcoholic, we really need to document this. Well, it turned out what was going on was, there was sort of a high prevalence. I mean, not huge, but I think we had, about a third of the injured patients actually reported drinking prior to the event, which was actually some of the highest statistics we found anywhere in the world. But what was going on was that the same people with alcohol problems kept coming back to the emergency department. And so they sort of just saw them as overwhelming the system, but it was really sort of the same people. And so we tried not to include the same people unless it was the same person in for a different injury event, and then they were included twice, but the same person just coming back over and over with nothing really going on, which was sort of happening at San Francisco General, because they would sort of come in and sleep on a gurney and get free bus tokens and free bag lunches and a shower, and so it was to their advantage to come into the emergency department, but those weren't really the people we were interested in. So anyway, prior ED visits is important, and then of course the demographic characteristics. This just shows a little causal model of alcohol consumption and resulting harms. And the main point here is that both patterns of drinking and average volume through mechanisms here contribute to chronic disease and injuries that we're interested in, and of course acute social and chronic social harms as well. So the purpose over all of these studies was to actually document alcohol's involvement in injuries, the prevalence, and then to explore the association of drinking patterns and drinking contexts with injuries. And we have found in our studies that the associations are fairly consistent across ED studies. Alcohol is involved in injury more than one would expect by chance, and certainly more than it is in non-injury events. However, the magnitude of that association has really changed dramatically. As I said, San Francisco General had probably the highest alcohol involvement, and probably the lowest has been at this HMO called Kaiser Permanente in California, where we found a very low percent. So depending on what emergency department you go into, really depends on how big alcohol looks as being in the picture with injury. And so we were very interested in trying to understand the heterogeneity of this alcohol-injury relationship. So what I want to do is to give you a couple of sort of sample analysis that we've done that I think have been two of the most important. The first is what's called a case crossover analysis, and it's a dose response. So not only are we looking at people reporting drinking prior to the injury, and we generally look at drinking within the 6 hours before injury, but we're also looking at the amount of alcohol they report to have consumed. And this is analysis of 18 countries and over 13,000 injured patients. So this shows a basic dose-response relationship. And as you can see here on the I have trouble with this little arrow too. This seems to be gone. Oh, here we go. Okay, so we have the number of drinks down here, and this line is the risk of injury. So, as you can see, risk increases from 1 drink on to about 20 or so, and then risk seems to decline. Of course, some of the problem with these kinds of figures and all is that there are fewer people drinking really high amounts, because now, remember, we're looking at the 6 hours before injury. So if you're drinking 20 drinks within 6 hours, I mean, that's a lot in a small amount of time. So if people are drinking even more than that, it's really a lot in a small amount of time. So you have fewer people drinking at that level, and so the figure ends up not being as stable on the top end because we just don't have the power and all and the numbers. However, my own feeling is that if someone drinks a certain amount, they aren't going to be able to injure themselves because they're too drunk to do anything. I mean, they're just going to pass out. And so there probably is some authenticity behind this kind of curve. But it's not to say that, oh, good, just drink a lot and you won't have an injury. I think that's the picture here. Okay, I think this is pretty interesting. I think Tim thinks it's interesting too. That this is a dose-response relationship by gender. And as you can see at the bottom here, it's pretty even. Actually, when you look at the numbers, it's pretty identical through 3 drinks. And at 4 or more, it starts separating to where women, this arrow is, there it is, okay. Women actually have a higher risk or more rapid increase at the same level of consumption than males. Now I have to say again, because of numbers, this does not become statistically significant until you get to the very upper range here. Well, anyway, you can see the upper. I don't know why this arrow just is gone half the time. Well, anyway, you can see what's happening. Okay, this shows the same thing for age. This sort of surprised me. I would have thought that younger people, 18 to 29, might have been at higher risk than people over, but really not so. I mean, it's small. You can see a little bit of difference, but it's small. I think this is sort of interesting. This is the relationship by detrimental drinking pattern. And what that is, that's a country level measure of how detrimental a given amount of alcohol is in terms of harms. And it's based on things like the proportion of abstainers in the culture, the proportion of people who get drunk and actually drinking with meals, which are more protective. So it's based on a number of factors. Actually was developed by WHO. And the higher the detrimental drinking pattern level, 4 is the highest, and that's the most detrimental. So what's interesting is that you can see that the most detrimental pattern, there's the arrow, the most detrimental pattern here actually increases dramatically at very small amounts of drinking and then sort of levels off. Well, anyway, you can, I don't know, this arrow is so weird. It sort of levels off here, and the DDP2 is which is, well, DTP1, I'll say, it's not on here because only one country fit that. That was Switzerland, and so we can't, really include one country in this. DDP2 is the next least harmful pattern, and as you can see, that is below DDP3, which is higher and consistently higher. And DDP3 tends to represent more infrequent heavy drinking patterns, whereas DDP4 is more just heavy drinking. DDP4, the countries are Belarus, which is part of Russia. Well, it's a separate country now, it used to be part of Russia, Nicaragua and Guatemala, and Mexico. And here we have by cause of injury, and not surprisingly, violence-related injuries right up there at the top, and falls actually are a little ahead of traffic injuries here, and then that sort of low level is just other causes of injury that we sort of lump together. So, these data suggest high levels of alcohol-related injury associated with the burden to the healthcare system. That injuries play a large part, but it really varies according to some of these demographic and injury characteristics, as well as country-level characteristics as well. So next I want to go through briefly an analysis we did where we were, now this is shifting from drinking in the event, which this last dose response analysis was focused on. So this examines general drinking patterns of an individual, the individual usual volume of drinking, usual pattern of drinking. We also are interested in societal level volume and pattern of drinking, and pattern in this context being the detrimental drinking pattern, and then alcohol control policy in a country. So we defined alcohol-related injury by 3 variables. The drinking, any drinking within 6 hours prior to the injury, that's what we had in the previous analysis, but it was by volume. And here we weren't able to do that fine-grained analysis with the dose response here, so we had to just take any drinking 6 hours before. We also had 2 other alcohol-related injury definitions. One was a BAC greater than 0.08, and actually, that's less than. I mean, it was greater than. And causal attribution of injury to alcohol. So you might think of these 2 definitions as being a little more stringent. It's one thing to report, say, 1 drink within 6 hours prior to an injury event, but to have a BAC over 0.08 or to attribute a relationship between drinking and the event are sort of more definitive criteria. So, the individual level drinking measures, these were based on the last 12 months, the overall volume of consumption in standard drinks, each of which had 16 mLs of ethanol. and usual drinking patterns. And this was a frequency of drinking weekly, and then the frequency of 5 or more drinks weekly. The study level drinking measures were the average 12-month volume. That had to do with across all patients in a given emergency department in a country, or if we had more than one emergency department in a country, it was averaged volume across the country emergency departments. And then the pattern measures, I said, was the detrimental drinking pattern. The study level policy measures were drink driving policy and alcohol access. Drink driving, we sort of had a composite measure of legal level of intoxication for driving, random breath testing, sanctions against drunk driving, and open container laws. And I have to say, some countries did not know what an open container law was. So I thought that was sort of interesting. And then alcohol access policy, legal drinking age, off-premise sales restrictions, bar closing hours, and sanctions against serving minors. So, we have 3 or 4 tables just showing you the countries, and I will just sort of concentrate right here on Canada, if I can. There's my arrow. Okay, so you can see we had Edmonton and Quebec from the earlier studies. Orangeville was a WHO study in Ontario, and then more recently the Vancouver study. And what you can see here is what I think is interesting for Canada is that there's quite a range of the proportion of drinkers. You have 90% in Quebec down to 80% in Orangeville. And what's even more interesting, I think, is the alcohol use prior to the injury. In Orangeville, you have 7.8%, and in Alberta, you had 34.6%. And then you can see also Orangeville was low in BAC and in the causal attribution, whereas Edmonton was higher. You may be curious about the difference between Alberta and Quebec, and it's an example of what we have found similar in the U.S. when you compare the South, which is has a high rate of abstention and fewer drinkers, but those who do drink excessively, compared to, say, California, which has more of the Mediterranean drinking culture. That in Alberta is much more like the South in our country, where there's higher rates of abstention, and Quebec is much more the Mediterranean drinking culture, where wine is consumed with meals and so on. Yes?
Did you take into consideration the demographics of that area? Because Edmonton's like an oil town, right? So you have abstainers that go out on the rigs, and then they get periods of time off. They come into the city, such as Edmonton, and they overdrink.
Yeah, we didn't take specifics into consideration, but because there's a lot of that, I'm sure, across all these different sites, and that's a good point. But we do have some other data that sort of support this overall, but this is just from the one emergency department, and I assume there's more than one in Edmonton, so it really has to do with this one ER as well, or ED, so yeah. There's all kinds of things that can interfere with these data. Anyway, so we then have you can see there's just a large variation here, and coming down to the bottom line, we have 3/4 of the people are drinkers here. Over 25% reported using alcohol prior to the event. 12% had a BAC of over 0.08 or equal to, and 12% causally attributed the injury to the drinking. However, the BAC positive people are not necessarily the same ones that attributed the injury to the drinking. In fact, it's very interesting. Again, it really varies. That people who may attribute a causal association may not have a very high BAC, whereas others may have a really high BAC and don't attribute it. So, because the attribution is a very subjective measure. whereas certainly the BAC is not. And we actually found self-report is very accurate too. We have found in our studies that there's, sort of like half of 1% who deny drinking prior to the event who are positive on the breathalyzer. This is controlling for drinking after the event too, because some people may not drink before the event and hurt themselves and have a couple of shots and then run to the ED. So, we don't care about those people. So we throw them out of this analysis. But very few deny drinking who have been drinking. But what we did find, interestingly, is that there's 40 or 50% of people who say they have been drinking who are actually negative on the breathalyzer. And that's because of the amount they've consumed within the 6 hours. If they just had a few drinks early on, then they aren't going to, by the time they get to the emergency department, and we do breathalyze them immediately after they arrive, so we do have this 6-hour time frame, but even so, if you've had a couple drinks 6 hours ago, you aren't going to be positive on the breathalyzer when you get to the ED. So anyway, that's sort of what's going on there. Okay. So these are analysis for drinking prior to injury. That's any drinking within the 6 hours. And here you can see, that arrow is so problematic, I think I'm just going to use this. So you can see that here we, so where is the arrow? There, okay. So you can see that the volume consumed, the individual volume, is predictive of drinking prior to injury, which is no surprise. And then here you can see, moving on down, that we've added the pattern of drinking. And here you can see that both infrequent heavy, if you're a frequent light drinker, and infrequent heavy or frequent heavy drinker, that is also predictive. Oh, good grief. Well, here, let me go back. Well, neither one of these arrow situations seems to be working very well. But maybe you can sort of follow along here. So we've taken volume out, but we have pattern. And then we've added volume back with pattern. And here you can see that any heavy drinking, infrequent or frequent heavy drinking, along with volume, is predictive of drinking prior to injury. Now we've added the study level. Volume is predictive, and detrimental drinking pattern is only marginally predictive. We've added back in the drinking pattern. You can see that any kind of heavy drinking is still predictive, along with individual level volume and study level volume. But the detrimental drinking pattern now is not an important predictor at the country level. And here you can see the final model where we have alcohol policy. And as you can see at the bottom, neither the drinking policy or the alcohol access are predictive of drinking prior to injury. Now I'll show you the full model for BAC greater than 0.08. And if you look at the last column, you will see that actually now both driving policy and access policy are predictive of having a positive BAC, as well as the other, in fact, all of these pretty much are predictive, the individual level factors as well as the study level. And then the same for causal attribution. Actually, I'm sorry, with the BAC, only the driving policy was significant. Those are the little two asterisks, whereas alcohol access was not for BAC. But then if you go on to causal attribution, both policies were predictive of a patient attributing their injury to drinking. So we found that individual level volume predicted all three of the alcohol-related injury measures, and the drinking pattern controlling for volume also was predictive, especially for episodic heavy and frequent heavy drinking. Those were the most predictive patterns. So it's not just drinking in the event, but it's also your usual pattern of drinking. And we found that the policy measures were more predictive of more restrictive definitions of alcohol-related injury, so they were predictive of the causal attribution in the BAC, but not for self-reported drinking. And as I mentioned, that self-reported drinking, any drinking 6 hours before, may not be a good measure of alcohol-related injury because of perhaps a small amount that was consumed early on. So with the policy, the stronger the policy, we found the lower the rates of alcohol-related injury. And one problem is that we had a composite of the driving-related policy and a composite of the alcohol access policies. But so individual policies within those composites might have been more predictive of certain kinds of alcohol-related injury. Also, we grouped all the alcohol-related injuries together, and if we had, for example, separated out injuries from motor vehicular accidents, then probably the policy related to driving would have been much more predictive, as one would expect, whereas alcohol access policy might have been more predictive of violence-related injuries. So these are the kinds of analysis that we plan to do as we collect more cases. One can only do so much, even though it seems like we have a lot of injury cases. So there's more, these sort of give us a guide as to more kinds of things that we need to do to really better understand the alcohol-injury relationship in terms of a number of factors, including policy and by type and cause of injury. So basically then overall there's some implications of these ED studies. They certainly contribute to our knowledge base on the prevalence of alcohol-related injuries and the burden in ED caseloads. Risk of injury, they provide knowledge related to the dose response that we talked about, chronic consumption and drinking patterns, type and cause of injury, alcohol control policy, and demographic characteristics and other variables as well. They also inform monitoring of alcohol-related injury at international, national, and community level. I know that CAR-BC, with Tim and Kate being largely responsible, had a monitoring program for what, 2 years was it, or more? 4 years. Yeah. How time flies. Yeah. And so these data are really important for informing those kind of monitoring efforts. And they also inform the development of interventions. We have found through these studies that alcohol is highly overrepresented in emergency departments, both with injured and non-injured patients, than in primary care settings or the general population or other places. So this has helped inform the need for and the kind of brief interventions that are really useful in the emergency department. We've actually done this in Poland and also more recently at the U.S.-Mexico border in terms of implementing brief intervention studies in the emergency department. These data have also been useful for establishing and updating safe drinking guidelines for Australia and Canada, primarily thanks to Tim's efforts. Also updating the global burden of disease estimates for alcohol-related morbidity, calculating the economic costs of excessive consumption in the U.S., and also they were used for informing the formulation of the new DSM-5, which is sort of a radical revision of the old DSM-4 criteria for alcohol use disorders. And we have had 2 books. Tim has co-authored these with us. This one was put out by the World Health Organization in 2009. And then more recently, we have a book that was published by the Pan American Health Organization, and this came out just last December.